Good evening. Thank you for having me here to share with you on the iron deficiency anemia. I believe that this is a growing public health emergency, and I think we as the healthcare providers and those involved with health in children would like to know a little bit on iron deficiency anemia and what we can do to help prevent this from continue to rise in terms of the prevalence in Malaysia.
Folks, a very good evening to each and every one of you. Our symposium for today will be starting not too long from now, but in the meantime, just a couple of announcements. Now, this meeting is for educational purposes and is intended for healthcare professionals only. I'd like to remind that participants are not encouraged to record or screenshot the presentation's content during the meeting. The official recording will be made available from the organizers after the symposium. Now, the content of today's presentations is the sole opinion of the speakers based on her or his professional knowledge and experience. An important note that we'd like to highlight is that you are required to change your display name to your full name as per your IC for CPD points purposes. Please note that we are unable to register your CPD points without your full name. So again, we'd like to encourage you to change your display name right now if it is different. Please remain muted throughout this session. And during the symposium and discussions today, the chairperson will be initiating questions and feedback with the speakers. During this time, you may drop your questions in the chat box. We'll tell you more about this a little bit later. Folks, we'll be starting not too long from now. Thank you.
Good evening. Thank you for having me here to share with you on the iron deficiency anemia. I believe that this is a growing public health emergency, and I think we as the healthcare providers and those involved with health in children would like to know a little bit on iron deficiency anemia and what we can do to help prevent this from continue to rise in terms of the prevalence in Malaysia. Good evening. Thank you for having me here to share with you on the iron deficiency anemia. I believe that this is a growing public health emergency, and I think we as the healthcare providers and those involved with health in children would like to know a little bit on iron deficiency anemia and what we can do to help prevent this from continue to rise in terms of the prevalence in Malaysia.
Once again, folks, a very good evening and a warm welcome. Our symposium for this evening will be starting not too long from now, but again, for the benefit of those who may have just joined us, just a quick, some housekeeping announcements here. Our meeting today is for educational purposes and is intended for healthcare professionals only. We'd like to remind that delegates and participants are not encouraged to record or to screenshot the presentation's content during the meeting. The official recording will be made available from the organizers after this symposium. Now, the content of this presentation is the sole opinion of the speakers based on her or his professional knowledge and experience. A very important note here, we'd like to ask for everyone to change your display name to ensure that it is your full name as per your IC for CPD points purposes. Please note that we are unable to register your CPD points without your full name. Folks, we will keep you muted throughout the session, but during the discussions during today's symposium, the chairperson will be initiating questions and feedback with the speakers, and during this time, you may drop your questions in the chat box. We'll explain more a little bit later, but for now, for those who have just joined us, we say thank you, hang in there, we will be starting very shortly. Thank you.
Good evening. Thank you for having me here to share with you on the iron deficiency anemia. I believe that this is a growing public health emergency, and I think we as the healthcare providers and those involved with health in children would like to know a little bit on iron deficiency anemia and what we can do to help prevent this from continue to rise in terms of the prevalence in Malaysia. Good evening. Thank you for having me here to share with you on the iron deficiency anemia. I believe that this is a growing public health emergency, and I think we as the healthcare providers and those involved with health in children would like to know a little bit on iron deficiency anemia and what we can do to help prevent this from continue to rise in terms of the prevalence in Malaysia.
Once again, folks, very good evening and a warm welcome. Our symposium will be starting not too long from now. Just a few quick announcements. Our meeting today is for educational purposes and is intended for healthcare professionals only. Participants are not encouraged to record or to screenshot the presentation's content during this meeting. The official recording will be made available from the organizers after the symposium. Now, the content of today's presentation is the sole opinion of the speakers based on her or his professional knowledge and experience. Again, just a quick reminder for the benefit of those who may have just joined us, you are required to change your display name to your full name as per your IC for CPD points purposes. Please note that we are unable to register your CPD points without your full name. For those who may not have yet done this, please do so now. We'd like to ask that you remain muted throughout the session, but during the discussions, during our symposium today, the chairperson will be initiating some questions and feedback with the speakers. And during this time, you will be able to drop questions in the chat box system. We'll tell you a little bit more about that as we move along, but for now, hang in there, folks. We will be with you very shortly. Thank you.
Good evening. Thank you for having me here to share with you on the iron deficiency anemia. I believe that this is a growing public health emergency, and I think we as the healthcare providers and those involved with health in children would like to know a little bit on iron deficiency anemia and what we can do to help prevent this from continue to rise in terms of the prevalence in Malaysia.
Once again, folks, a very good evening and a warm welcome. Our symposium will be starting very shortly, but for the benefit of many who have just logged in and joined us, just a quick few housekeeping announcements here. Our meeting, our symposium for today is for educational purposes and is intended for healthcare professionals only. I'd like to remind the participants are not encouraged to record or to screenshot our presentation's content during the meeting. The official recording will be made available from the organizers after the symposium. Content of this presentation is the sole opinion of the speakers and will be based on her or his professional knowledge and experience. I'd like to remind to change your display name on screen to your full name as per your IC for CPD points purposes. Please note that we are unable to register your CPD points without your full name on screen. We will be keeping you muted throughout the session, but during the discussions today, the chairperson will initiate questions and feedback with the speakers, and during this time, you may drop questions in the chat box. System will tell you more about it. Hang in there, folks. We'll be starting very shortly. Thank you. Hello there, folks. A very good evening and a warm welcome to our first virtual symposium that is proudly hosted by the Malaysian Pediatric Association along with the Malaysian Medical Association. We thank you for your patience as we were just gathering all our healthcare professionals into the room. My name is Melvin Area, your MC for the day, and on behalf of the MPA, MMA, and in partnership with the Non-Nutrition Research, we'd just like to say a very big thank you to each and every one of you for taking some time out of your very precious Saturday evening to join us in the symposium that is entitled The 3C's of Picky Eating: Context, Consequences, and Correctives. Now, before we dive into our symposium proper, the Non-Nutrition Research would first like to take the opportunity to thank the Malaysian Pediatric Association and the Malaysian Medical Association for this very first education partnership on this new virtual platform. Now, at the Non-Nutrition Research, science is at the very heart of our nutrition and health commitment. We focus our skills and resources to deliver evidence-based nutrition because we understand the importance of supporting you, our healthcare professionals, with the latest science, research, and development findings. Now, our symposium today has been put together with you in mind to provide the latest evidence-based information and practical knowledge to support you in your clinical practice. So this evening, we're going to be munching away on this very prevalent topic, the topic of picky eating. Now, for many of us as parents ourselves, we know how common the issue of picky eating is. Not just common, but in fact, sometimes it's worrying, sometimes it's frustrating. We know how it feels. Now, the question is it a common issue in Malaysia? Should we be worried? What are the latest evidence suggesting? What advice should doctors and healthcare professionals like yourselves be extending to parents? Folks, all those questions and more will be covered in today's 2-hour program that the organizers have got lined up for you. We'll have some lectures and go through a few case studies. And along the way, we'll also be asking your thoughts through some polling questions. Now, what happens there is this. A window will pop up with a question and some answers right there. You'll just need to click on your choice of answer, and soon after, we'll have a look at the results together. Okay? Now, to get us all familiarized with that, we're going to try out a few questions. Are you guys ready? So, again, hands on your mouse, so reach out for your mouse. For those who are on your mobile devices, joining us from your mobile devices, the screen will just pop up, so you just have to click on your mobile devices. Okay? If you guys are ready, let's dive straight into it now, shall we? Okay, so the first question that we want to know, we want to get a sense, where are you guys from? Or where are you folks tuning in, watching us from? Are you up in the northern region? Are you in the East Coast? Are you in the central region? Are you down south in the southern region? Or are you across the South China Sea in East Malaysia? Or are you across the causeway at Singapore or are you from somewhere else altogether watching us and joining us in today's symposium? All right, so folks, key in your answers, and we'll have a look at it in just a moment. It'll be very interesting to know where you guys are all watching and tuning this broadcast of this medical symposium from. Yeah, key it in. So remember, just go ahead, pick one. All right. All right, let's have a look at the results. Let's see where all of you folks joining us from. Let's have a look. We're gonna see this in terms of percentages. So a big chunk coming from the central region. We've got quite a fair bit of you up north also. And then of course, East Coast, salam sejahtera, selamat datang, selamat petang pada anda semua. Of course, southern region, East Malaysia, very good. And of course, quite a very small number there, 2% there from somewhere else altogether. Thank you for joining us. Let's go to the next question, folks. Let's have a look. Okay, so the next thing we want to know is this. Now, do you work in the public or private sector? Again, are you working in the public or are you in the private sector? Okay, so click away your answers. Let's have a look. This one right here. It's all very quickly coming in, the answers. Let's have a look at the results and see where are all of you folks from. It's a fair share right here, split smack across in the middle. 50% on public and another half from the private sector. Very nice, very cool, very cool. Okay, last one, let's try this out. Let's dive in a little bit deeper. What is your profession? That's the next question. We want to know which field of practice you are in. We've got a couple of answers right here for you folks. We want to know if you are a pediatrician. Don't worry, it'll be coming up in just a second. So essentially, we want to know what is your profession, what is the field of practice that you are in, okay? The answers are going to be coming up in just a moment. There we go. So are you a pediatrician? Are you a dietitian? Are you a nutritionist? Are you one of our GPs? Or are you one of our MOs? Or are you a nurse? Or any others? All right, so keying in. Ooh, again, answers are coming in fast and furious. You guys are getting the hang of it. That's very cool. So this is what we're going to be doing a lot, okay? This is the final question for now. And answers are all coming in furious. So let's have a look. Let me just give it a few more seconds. Let's have a look at the results now, shall we? A good chunk, as we expected. A lot of our peds with us. We have got a good number of dietitians and MOs who are joining us also. And as we go down the line, a lot of GPs, nutritionists also joining us, and a whole bunch of others. So that could be probably some ONGs right there, and perhaps a few others. So, but yes, that's what we will be doing, folks, throughout this evening symposium. We thank you for giving us your answers. Now, the thing is this, today is not just about us asking you questions. Now, as our symposium progresses, you too will be able to pose questions to our speakers, all right? Now, so if you have a look at your screen, towards the bottom, you'll see that there is a chat icon. All right, for those, if it's not there, all you have to do is use your mouse, hold onto your mouse, just hover your mouse towards the bottom of your screen, and then a whole black bar will pop up with a couple of icons. Now, if you see that there's a little icon that says chat, click on that, and that's where you post your questions to us. So, of course, we will be limited by a little bit of time constraint to answer all your questions during the symposium, but we will address them post-symposium. So we want to encourage all of you good folks to post your questions as we move along, all right? So after each case studies, we'll go through some Q&As, and then at the end, at the tail end, we'll go through a generic Q&A to cover everything. That's the plan for today. Are you guys all set? Nice. Folks, we want to encourage you also, if you've got a pen and paper nearby, just bring it nearer to you. If you don't have, quickly go grab a piece of paper, a pen or a pencil, you know, have a glass of water, a cup of tea in front of you, because this is going to be a very interesting next 2 hours. First up, to allow me to give you some introduction, a brief insight into our chairperson, who, well, actually is no stranger to many of us. Folks, chairing and moderating our symposium for today is Dr. Zulkifli Ismail, a consultant pediatrician and pediatric cardiologist who's practicing at the KPJ Selangor Specialist Hospital. Now, Dr. Zul is, of course, the former president of the Malaysian Pediatric Association and is currently the editor of the MPA News, a bulletin publication that is distributed to fellow members of the association. He's also the head and editor-in-chief of the Positive Parenting Guide, a publication that aims to complement parents' knowledge in pregnancy, childcare, and family. Dr. Zul is also currently the Secretary General of the Asia Pacific Pediatric Association, along with being its immediate past president, and is also the current head of the Asian Strategic Alliance for the Prevention of Pneumococcal Diseases. Now, he has had more than 35 publications in international and local peer-reviewed journals on various issues involving child health, pediatrics, and vaccines. He was awarded the rank of Regional Crown Commander by the King of Malaysia, which bears the honorary title of Dato in 2008. So folks, I'll leave you in the good hands of our chairperson for today's symposium. Please help me welcome. It is Dato Dr. Zulkifli Ismail.
Thank you, Melvin, for that introduction. And on behalf of the Malaysian Pediatric Association, I'd like to thank Danone Nutrition Research once again for sponsorship and supporting of this successful event. I'm particularly pleased to see so many of you joining us. We've got, I think, about 400 participants, and the number is increasing. And we've got among them, of course, we've got pediatricians from both the public and private sector. We've also got medical officers, dietitians, nurses, and I hope that you'll find that this session will be useful and relevant to your practice. So further to the first set of polling questions that we did, we'd like to now know more about your practice relating to the topic that we are talking about today, which is picky eating. So are you ready for the polling? Let's have the first question. So the first question is, in your practice, roughly how many % of patients that you see are picky eaters? Just choose one of them. Well, either you don't see any, or you see 1 to 10%, or 11 to 30% of your patients, or 31 to 50%, or more than half of your patients are actually picky eaters. Please, you have about 15 seconds to answer. Okay, the answers are coming up now. So let's see what answers we've got from the people attending here. Okay, so we've got 30% of you saying that you've got 11 to 30%. I'm sorry, 35%. 11 to 30%. Okay, the number is a bit difficult to read this chart now. 35% of you say that you see about 11 to 30%, and then there's still about 11% who see more than half, which is quite good. So there's a lot of interest in picky eaters, and let's see what the next question is all about. Let's ask the next question, all right? So the second question here is this: what do you think is the most important health concern for picky eaters? Is it growth? Is it micronutrient deficiency, family stress, long or short-term health consequences, or you think that all four of them is relevant? So let's see in 15 seconds what your answer is like. All right, we're getting some answers now. Let's see what's okay, so have you got the answers? All right, so well, most of you answered that all of them are relevant. Right, okay, let's see what the results, what our two speakers will be talking about later. Let's see what the next question is. And the next question is, how do you usually manage a picky eater? We're talking about management now. So number one is you actually manage on your own with some dietary advice and parental education, or you refer to a dietitian or a nutritionist for intervention, or you refer to a child developmental psychologist, or you refer to some other specialist, or you prefer not to discuss with the patients because you don't know much about the topic. So let's see your answers in about 15 seconds. Okay, right. Let's see the answers. Okay, so a lot of you manage on your own, and some refer to a nutritionist, but not many actually refer to a developmental psychologist, which is, I guess, quite fair. And not many of you are actually in denial or that you don't know about the topic. Right, thank you very much for your feedback. And as we can see, picky eating is a common issue in Malaysia. And I, for one, just like all of you here, look forward to hearing from the two speakers, Chris and Prof. Yazid, on what we could do for our Malaysian children on picky eating. So first of all, I'd like to introduce and welcome Chris Smith, who is joining us all the way from UK today. And Chris has been working as a dietitian for over 15 years, specializing in pediatrics for 13 of those years. And he currently specializes in infant nutrition and growth, gastroenterology conditions, and cystic fibrosis. And he's a senior pediatric dietitian and clinical lead in the Royal Alexandra Hospital for Children in Brighton, UK. And he being working in a busy NHS children's hospital gives Chris a huge experience of many pediatric conditions and their impact on nutrition and successful interventions. So he's going to be giving us a talk today, which is entitled Makeup and Diagnosis of Mild to Moderate Picky Eaters. So welcome to Malaysia, Chris, and the screen is all yours.
Well, it's a great honor and a huge privilege to be joining you today. Thank you to Nutricia for organizing this event and for inviting me. Thank you all for taking the time to attend. I wonder how many of you have been asked by a parent of a child with picky eating to give them advice and to give them help. Well, if, like me, I suspect it is lots and frequently, then hopefully the information I share with you today will be useful. What I hope today to do is to show you what the literature teaches us on the topic of picky eating. I want to share with you the assessment of a diet of a child with picky eating and the limitations that can be there to make sure your assessment is efficient and effective as possible. I also want to provide you with some clear assessment tools and advice that is evidence-based. And today I'm basing all of this on 4 key messages that I have for you. The first key message is that picky eating is a global issue. And I'm going to share with you the data that underpins this. The second key message I have for you is that we need to be aware of the possible consequences of picky eating on the child. I'll share with you the data that we have around this topic. A third key point is that a good quality dietary assessment of a child who presents to you with picky eating is key. And I will show you how to do that. And lastly, that when we see children with picky eating, we most likely need to give nutritional advice as well as behavioral advice to create the best outcomes for the child. So I want to start by talking a little bit about the facts and the figures surrounding picky eating. And the first fact of the matter is that there is no universal definition of picky eating that is agreed internationally. Various groups have proposed various different definitions from different researchers, different dietitians, psychologists, but there is no consensus. Therefore, it may be prudent to consider picky eating as an umbrella term that it encompasses many characteristics, most commonly an unwillingness to eat familiar foods or an unwillingness to try new foods. And it's probably best to consider picky eating upon a spectrum. And as you see illustrated here, it's much more common for us to see mild to moderate picky eating behaviors, and rarer, more severe cases of picky eating do exist, but we're least likely to see those in clinical practice. It may also be useful to use an alternative model when we're thinking about this spectrum. Here, of course, we see the healthy, well child with appropriate growth, with no concerns from the family about the quality or the quantity of the diet. But a child may enter the picky eating spectrum at any point. And initially, we may see a decrease in the quality or the quantity of the diet, and this may lead to an increase in parental concern and a higher risk of nutritional deficiencies. As picky eating develops, we may see it start to have an impact on growth objectively, with a flattening of the growth curve. This may be associated, of course, then with additional concerns from the families, as well as additional risks associated with the impact of reduced dietary diversity. Then at the far end of the picky eating spectrum, we see the children where we see an impact on growth that is negative, where they lose weight. This, of course, causes huge amounts of parental concern and puts them at the highest risk of micro or macronutrient deficiencies. Now, wherever a child may find themselves on the spectrum of picky eating, the reason they got there is most likely multifactorial. Now, a group from published their data from this year, propose a very nice conceptual model that illustrates all the etiology factors to consider. You can see it's illustrated here that it is the child's characteristics, as well as the parents' feeding beliefs, the parents' feedings, and the emotional climate of the mealtime that can all interlink and cause picky eating behaviours to either develop or to be exacerbated. Now, we don't have time today to talk about all the factors surrounding this, but the key point to remember here is that picky eating etiology is most likely multifactorial, multidimensional, and interrelated. So 2 key facts about picky eating: we have no universal definition, and the causes are most likely complex and multifactorial. What about the figures? Well, about 10 meters from where I stand now is my clinic room where I see children who have picky eating behaviors. Despite the fact you are 10,000 kilometers away from where I stand now, I suspect that you get asked the same questions and face the same concerns that I do just 10 meters to my left. And the data supports this too. This group from 2015 aimed to bring together all the prevalence data that we see surrounding picky eating globally, and I've illustrated it for you on this map. Since this time, there have been some notable additional studies to add on here. Firstly, of course, we see the data from Singapore, very close to geographically yourselves. And then we saw this data in 2016 from Nigeria, the first data on picky eating in a developing country. And then in 2018, data from Taiwan and data from Indonesia, and most recently, now data from Iran, Iraq, and Kurdistan. But there are 3 key points that I wish that we would understand when we look at the data presented like this. The first is that there are inconsistencies in the definitions used for picky eating across the majority of these studies. And this goes some way to explaining why we see very large ranges of picky eating prevalence, for example, in the US and China. Because on one end of the spectrum, we have studies that recruit children based on objective criteria that are robust. And on the other end, we see some studies recruiting and including children based on a simple one-word answer to a question whether their child has picky eating. The second key point to mention is that it is very difficult to interpret what happens with the prevalence and trajectories over time. And this is because the majority of studies use different age ranges, and the majority of studies are cross-sectional rather than longitudinal. We do have some longitudinal data, and you can see this paper published from the US that looked at prevalence, incidence, recovery, and persistence of picky eating up to the age of 11. And if I just draw your attention to the incidence data, what they were able to show, which fits very nicely with previous data, is the greatest chance of picky eating occurring is in the children under the age of 4 or 5, and the chance of picky eating developing after the age of 5 is really very rare. And the third key message I have for you is that picky eating is an international concern. And we can see it's gaining international interest. If we type the term picky eating into a search engine such as PubMed, what you see from the results is an explosion of papers and literature on this topic just in the last 10 or 20 years. So hopefully I've been able to show you that picky eating is a global issue, with increasing data being published from an increasing number of countries. The next key point is that we need to be aware of the consequences of picky eating. And broadly speaking, these can be split into 3 different areas: concerns about growth, concerns about specific nutrients, and concerns about behaviors. So let's start by looking at growth. Several studies have identified that picky eating children have a higher caloric intake than children who don't. Some studies showed no difference in caloric intake, and others showed a reduced caloric intake in these children. To try to answer this question, a very nice systematic review from 2018, shown here, has looked at the outcome of caloric intake and looked at growth. What you see from the studies is a large number of studies showing no association with picky eating to weight, but 11 studies showing a negative association of picky eating associated with a lower weight. But interestingly, we're also seeing a small number of studies associating picky eating with an overweight status. Now, as I mentioned, most of the studies that we see in picky eating are cross-sectional, but there are some longitudinal studies. And a recent UK study provides some very robust and reassuring growth outcome data. As you can see here, this looked at the children who had very picky eating behaviours, followed these children up until age 17, compared them to the children who didn't have picky eating behaviours, shown with the green triangles. And what is clear is that across this age range, both the children with a history of picky eating and the children without a history of picky eating maintained BMIs above the 50th centile. So this is overall very reassuring. Another concern is about the impact of specific nutrients from picky eating behaviours. And this review paper from 2018 identifies 28 studies that looked at dietary intake in children with picky eating. It identified that, broadly speaking, intakes of fruit and vegetables and meat and fibre may commonly be associated low picky eating children. There are several studies, however, that have microscoped down to a better level, and some examples are shown here. For example, the data would support that macronutrient balance does not appear to be significantly influenced by picky eating, although the UK and Chinese studies showed a lower prevalence of protein intake, but still within ranges. Of course, this is important in the age group when picky eating occurs because of its influence and impact on growth. We also saw a microscope of micronutrient intakes in both the UK and the Chinese study, suggesting that there were lower intakes of iron and zinc in these groups. And this, of course, is particularly important, again, because of the role of iron and zinc in brain development, which is most rapid in this time frame that we're seeing. And lastly, there are concerns about the impact long-term of behaviours on children with picky eating. However, the data surrounding this is a lot less conclusive. Of note, two interesting new studies, these ones from Taiwan and from Iraq and Kurdistan, would suggest that there may be an influence on picky eating behaviours to physical activity in those children with picky eating versus not. And they also suggested there may be certain aspects of social development and communication that may be poorer in the picky eating child. But again, it is too early to draw too much conclusion from these. So hopefully, broadly speaking, you can see that the literature supports some reassurance as to only significant picky eating causing negative consequences in children. Now, despite the fact that most of the data is reassuring, what we acknowledge is that parents are concerned about these consequences. And in this very nice study undertaken in Singapore, this illustrates the point very nicely. In this study, they identified that 83% of parents or carers were concerned that the picky eating would have a negative impact on the child's growth. And over half were concerned about the impact on the mental development of their child because of picky eating. So superficially reassuring our parents that there is nothing to worry about will leave the families feeling not listened to and may lead the problems to be exacerbated and certainly become more stressful. So we need to appropriately assess the children to conclude correctly ourselves and for the parents. Now, you will hear from Prof later on about the assessment of these children from a medical point of view, but I'm looking at it from a diet point of view. So there are 4 key ways that we can assess diet in children who present to us with picky eating. A 24-hour recall is a very quick and easy way for us to collect dietary information, but the data may not be representative. We can do food frequency questionnaires, which are very useful at looking at specific nutrients like iron. However, they can be quite time consuming for the families. We can do 3 to 4 day food diaries, which give very accurate information about a child's intake, because they often include portion sizes, but they can take a time for the families to complete, and if we need to analyse them, this prevents more of a burden. And we can, of course, use dietary diversity scores, and these can provide very robust and accurate results. However, they are most accurate in the populations they've been designed for, and extrapolating them to different populations may increase the limitations. So all of these methods of dietary assessment, particularly for a child with picky eating, we need to recognise the limitations, and these were highlighted in this paper from 2018 that suggests that all of these methods rely on memory, which we know is very poor in humans. They also follow proformas or protocols, which may induce false memories. And we know that they can't be independently verified, and therefore they have significant limitations there. But whilst we understand all these limitations, we can try to minimize them. And when we're doing dietary assessments on the children, it's very important we emphasize to the families we want these to be true, we want these to be accurate and detailed, and we want them to be representative of the child's diet. This will allow us to make the best assessment for the child. There are other ways we can do dietary assessments too. We can look at the outcome of intake, which is deficiencies. Many of you will be aware of this paper published just last year from Espegan, and it teaches us how we should interpret micronutrient or vitamin levels biochemically. And certainly the first thing we need to be cautious of if we use these is the influence of the systemic inflammatory response, which can alter the results and make our interpretation incorrect. Espegan suggests that if we're going to use biochemical markers to assess nutritional status, we should be doing it within a multimodal approach. And that means including doing a clinical assessment, looking for symptoms and signs of deficiencies, as well as doing your detailed dietary assessment to indicate any likely low levels. And doing this approach altogether is the approach that will most likely give you the most accurate and the most optimum responses. And I want you to remember that when we're doing dietary assessments on children, particularly with picky eating, it's not just what they eat, it's also how they eat that's really important. Now, there have been several different questionnaires that can be used in picky eating to look at how children eat. The most common one in the picky eating literature is the CEBQ. There may be many advantages to using such questionnaires in your assessment of dietary intake, not least because some of these are validated. They are also very efficient uses of your time, as they can be completed ahead of your appointment and therefore save you time. They can help guide the advice by making it much more bespoke once you've identified what the behavior issue is. And they can be repeated later on, which very accurately can help assess the child's progress. Another key aspect that we need to do in our dietary assessment is also looking at how the parents are around the meal times. We want to look at the parenting style. And the simplest and most crudest way of doing this is to ask the parents, what do you do when your child doesn't eat? Because a responsive parenting style will listen to that child's cue and not force them and lead them to the next meal. A controlling parental style will force their child or punish them. An indulgent parenting style will offer a variety of different foods in a desperate attempt to get the child to eat. And a neglectful parent will abandon responsibility. And of course, we want to guide our parents towards more responsive feeding behaviors if we want to have success with picky eating. So, I've been able to show you that the complete dietary assessment is key, not just looking at what the child eats, but how they eat and the emotion and the environment around which they do. The final key point I have for you is we need to manage these patients appropriately with nutrition and behavioral advice. So from a nutritional point of view, there are some key aspects. Number one, remember the role of nutrition. Key nutrients in childhood play roles not just in the short term, but in the long-term health and development of children. So emphasizing to the families the importance of dietary diversity is really important. We do need to monitor growth, looking particularly for tracking of centiles, proportional tracking as a very reassuring marker for optimal health. We need to concentrate on key micronutrients that we know may be a problem in picky eating behaviours, such as iron and zinc and fibre. And lastly, if we do need to address a child's undernutrition because they have poor growth, they will require extra calories. We want these calories to come in a balanced format: protein, carbohydrate and fat. And if we identify low micronutrients, then these will need to be addressed individually. In terms of behaviour, we have 5 key aspects. Firstly, role modelling has been shown for a long period of time to be very effective at improving picky eating behaviours. So allowing the child to see other family members eat exactly the same foods that they do will help bring about a resolution of picky eating. Secondly, we want to ensure that our families follow responsive feeding, looking and listening and understanding the child's cues around food, not simply forcing them or following their own beliefs about how much or when the child should eat. We need to be repeatedly exposing our picky eating children to foods we want them to eat, but in a non-threatening way, so they build confidence around these foods. We want to ensure that we educate the families on what is a realistic portion for the child to be having, so they're not over delivering foods to the child with this over expectation, which will only disappoint the child and the family. And lastly, we need to get the timings correct. A mealtime lasting more than 25 minutes for a child with picky eating behaviours will be upsetting for the child and stressful for the family. So limiting time frames for meals can be a very effective, proven way to help improve behaviours. So I hope today I've been able to show you what the literature teaches us about picky eating, and I've been able to share with you some key aspects and considerations for accurately assessing the diet in a child with picky eating. Hopefully you've been able to see that picky eating is a global issue with increasing data being published from an increasing number of countries. We are limited in the conclusions we can draw because of the fundamental limitation to the issues surrounding the definition of this condition. It's important that we're aware of the consequences of picky eating and that we assess the children on an individual level. Overall, there is reassurance surrounding the data on growth long-term in picky eating children. It's very important when we do a complete dietary assessment for a child, we look not just what they eat, but how they eat. And lastly, that when we're managing children with picky eating, we may require to give nutritional advice to maximize the health and growth of the children, and also give behavioral advice to improve those picky eating behaviors. So thank you very much for listening, and I'll be very happy to answer any questions surrounding this topic. Thank you.
Thank you, Chris, for the very clear presentation. And it's always enlightening to hear perspective from another country and also another profession. We normally hear from pediatricians, so it's a different thing to hear from a dietitian. So to the audience, if you have any questions, please feel free to ask them in the Q&A section, and so that we will address them at the end of the session. I'd like to now introduce the next speaker, Professor Yazid Jalaluddin. Prof. Yazid is the head of the Pediatric Department of the University Malaya Medical Center, or UMMC. And I think it's timely that we actually congratulate him because he has just been appointed full professor in the department. And he's also currently president of the Asia Pacific Pediatric Endocrine Society, from 2018 to 2020, and the immediate past president of the Malaysian Pediatric Association. He's also a member of the Endocrine Society USA and the International Society for Pediatric and Adolescent Diabetes and the Malaysian Endocrine and Metabolic Society. His main research interests are on growth, on obesity, type 2 diabetes, and vitamin D in children. And he's one of the clinical principal investigators for My BFF at School, and also another program called My Hearts, and a co-investigator in other research projects. And he holds many national and international research grants, and he's had countless publications in peer-reviewed journals like the New England Journal of Medicine, and also chapters in textbooks. And his talk will be on growth issues of picky eaters in Malaysia. What can we do? So the screen is all yours, is it?
Assalamualaikum warahmatullahi wabarakatuh, and good afternoon. I would like to thank Malaysian Pediatric Association and Malaysian Medical Association for giving me a chance to speak to you today on the 3C's of picky eating. I would like to also thank Danone Nutricia for asking me to speak today on the growth issues of picky eating, as well as the intervention strategies. Welcome to the webinar. For today, I would like to talk to you on the consequences of picky eating in Malaysia. We will then look into the current practices and management of picky eating in Malaysia, as well as looking at the management on the needs of the picky eating for optimum growth, basically looking at the roles of parents, the parenting styles, as well as oral nutrition interventions beyond calories. In late 2018, there was a report to say that Malaysia had this triple burden of malnutrition in Malaysia. This WHO report has mentioned that Malaysia had the problem of overweight, anemia, and stunted growth. Before we move on, let us describe what does it mean by the different terms that we use in growth. This table shows you that the normal weight is when the weight for each z-score is between -2 standard deviation and +2 standard deviation, while the normal height is when the height for each z-score is between -2 and +2 standard deviation. Wasting is defined as the low weight for height, whereby the weight for height z-score is less than -2 standard deviation. Stunting is when there is low height for each, which is when the height for each z-score is less than -2 standard deviation, and underweight is when there is low weight for each. The pictorial here may tell you a little bit more and giving you a better way of looking at these different terms. Let us look at the National Health and Morbidity Survey data. The one on the red is the NHMS 2011, and the one in gray is the MCHS 2016. If you look at underweight, there is some reduction of the percentage or the prevalence of underweight in Malaysian children below 5 years between the year 2011 and 2016. However, if you look at stunting, there is an increase over that 5 years from 18.7 to 20.7. Wasting, also there's some reduction from 19.1 to 11.5%. Let us look at some data that we have when we talk about feeding difficulty. This data was just published in 2019 in Pediatrics and Neonatology by Prof. Liwesia and his team. This data look at about 303 children, a cross-sectional study, healthy children in Malaysia and Singapore between the ages of 12 to 36 months. The parents were interviewed for concerns about their child's feeding and presence of behavioral and organic red flags for feeding difficulties. Growth faltering was defined as weight for each less than 3rd percentile and short stature as height for each less than 3rd percentile according to WHO growth standards. So what does this study found? This study found that 13% of these children had growth faltering, which is underweight, and about 19.5%, which is about 1 in 5, had short stature. Almost 1/3 of parents expressed concerns about their child's feeding behavior. 68% of them reported the presence of at least one behavioral, and about 20% of them at least one organic red flags. About 10% of them had both behavioral and organic red flags. I will talk to you more on what behavioral and organic red flags later. When they look further into the concerns of these parents, they found that growth faltering, which is underweight, was significantly associated with parental concern about feeding, food refusal, as well as presence of at least one organic red flags. However, there was no association between short stature and parental concerns, behavioral, or organic red flags. there are no further evidence coming from Malaysia when we look into the micronutrient deficiency, such as anemia or zinc deficiency, as well as long-term consequences on patients with feeding difficulties. Now, let us look at how to assess these picky eaters. How do we do the early detections? Before we move on, I would like to just introduce you the 3 different phases of growth in childhood, which are the fetus and infancy, childhood and adolescence. As you can see from here, nutrition plays a big role in all the 3 different phases of growth in childhood. Especially during the first 12 months of life, as you notice from here, the percentage of energy consumed for growth is very high, especially in the first 4 months of life, of about 27% of what the patient eats. So growth during infancy is most strongly influenced by nutrition. Nutrition also plays a big role when it comes to the growth plate. As you can see from here, there are many factors that affect the growth plate of a child. These factors include the endocrine, inflammatory cytokines, the paracrine, as well as the intracellular factors. And nutrition plays a critical role in modulating these levels and effects of hormones on the growth plate. Now, let us go and look into how to assess picky eaters. Most important thing is we have to get the history. Then we do all the measurement, the anthropometric, as well as doing the physical examination, trying to look for the organic red flags as well as the behavioral red flags before we do further investigations. The history assessment include the clinical complaints, the medical history, the social history, the family history, as well as the dietary and feeding history. Dr. Chris has mentioned to you earlier about the parenting style, and I would not dwell further into this, just enough to say to you that this is very important for us, even in Malaysia, to look into these different parenting styles of the parents nowadays. We need to understand what kind of parenting styles that they are demonstrating, such as the permissive parenting styles, either authoritative, authoritarian, or neglectful. Then we look into the ABC of assessing growth and nutrition in picky eaters. The A, basically the anthropometry. It is very important for us to take a proper height, weight, head circumference, as well as skin fold thickness. When we measure a child, it is very important for us to measure the supine length for all those children below 2 years. Even though they are able to stand, the legs has to be fully extended and the head is in Frankfurt plane. As for those who are more than 2 years old, a wall-mounted hypendent stadiometer is important. These children need to be fully erect with the head in Frankfurt plane, and all those back of the head, thoracic spine, buttocks, heels should be touching the vertical axis of the stadiometer. Once we have the weight and the height, as well as the head circumference and the skin fold measurements, we then need to plot them and compare it to the standard growth charts. As Malaysia do not have our own growth charts, we have to depend on the World Health Organization growth chart. Here I present to you all the different growth charts for the girls and the boys at different age group, for the weight, the height and the length, as well as the subscapular skin fold for each and the triceps skin fold thickness. Because of that, it is very important for us not to just take one time point of the height weight measurement, but it is very important for us to take serial measurement for us to understand the growth of a child. As you can see here, if you look at the first time point at the age of 4 years, A may be very healthy and good, and B may seem to be having problems. But as you further follow them up 3 years later, you notice that A actually has problem, but B may not really have a problem. So inadequate growth has been defined as anyone who had crossing down of 2 growth percentiles, or weight gain, which is inadequate for more than 1 month in a child less than 2 years, or even weight loss or no weight gain for a period of about more than 3 months in a child for more than 2 years, or if there is triceps skin fold thickness, which is less than 5th percentile for each. What are the organic red flags and the behavioral red flags that we need to look at when we assess picky eaters. The organic red flags include whether there is any history of dysphagia, aspiration, apparent pain with feeding, vomiting and diarrhea, developmental delay, chronic cardiorespiratory symptoms, as well as growth failure. When we talk about behavioral red flags, we need to look at whether there is any food fixation, noxious feeding, abrupt cessation of feeding after a trigger event, anticipatory gagging, as well as growth failures again. Now, let us look at what are the biochemical measures that we need to look at when we assess picky eaters. Before we assess, we need to understand if there is any red flags or not. If there is any red flags, then we would consider laboratory investigation. If there is none, we should proceed to evaluate and manage appropriately the nutritional intake. Lab investigation is not routine in patients with picky eater. Yeah, only about 1.4% laboratory tests were helpful in making a diagnosis. And testing should be based on the positive finding from the history and physical examination, generally targeted at specific underlying diagnoses that are suspected. Red flags require prompt attention and in-depth investigation. So what are the lab tests that we do? Full blood count, liver and renal function, urine tests, bone age for looking at the age of the child, nutritional testing such as the zinc, iron, and vitamin D, as well as the disease-specific tests. Electrolyte measures will will lead us to identify fluid imbalance. The serum iron ferritin will be able to detect the iron deficiency, either in the early, mid, or the late stage. And the C-reactive protein or cytokines will be able for us to identify the presence of inflammation. Now, let's look at the clinical observations. What are the physical examination? What are the signs that we want to look at when we talk about assessment? So here, it is very important for us to identify whether this is a chronic or acute illness, assess the degree of the undernutrition. We have to do the proper developmental assessment as well as looking at the anthropometric measurement. For example, we have to look at the skin, looking for pallor, looking for dry, scaly skin, or even a neckline dermatitis to look at possibility of iron or vitamin B deficiency or either fatty acid or biotin. We also need to look at the musculoskeletal, whether there's any twitching, whether there's any bowing of the legs, looking for any vitamin D or any calcium problems. Other areas include the nails, the neck, mouth, eyes, abdomen, and the hand. Once we have all this in place, we then need to manage this group of children. How do we manage them? Firstly, we need to first look into the parenting styles and feeding behavior. Again, Chris has already detailed to you about this, and I would not go into detail looking at parenting styles and feeding behavior. A recent publication by the Asia Pacific Academic Consortium for Public Health have given us some guidelines to improve complementary feeding. This is based on the WHO suggested minimum meal frequency, and I think this is also relevant to Malaysia. For those breastfed infants between 6 to 8 months, there need to be a minimum of 2 to 3 times a meal frequency. For those between 9 to 11 months, 3 to 4 times a day. Between 12 to 24 months, there need to be 3 to 4 times of feeding with additional nutritious snacks offered 1 to 2 times per day. And for those non-breastfed infants between the age of 6 to 23 months, 4 to 5 times a day meal frequency. APA-CPH also has mentioned that breast is best, exclusive breastfeeding to 6 months and continuing, while solid foods are introduced to 24 months or longer. They also suggest that the introduction of solid food should be done around 6 months of age. Mixed food is important. Dietary diversity is also important. There need to be food with various textures and tastes, but appropriate for age. And parents should practice responsive or responsible feeding as recommended by WHO. Okay, let us just look at the use of oral nutrition supplements. Nutritional support for children with faltering growth or at risk of faltering growth needs these oral nutritional supplements. It is useful to improve intake of children who are unable to meet their needs with normal food alone. ONS has been shown to be the simplest, most natural, and least invasive method of increasing the nutrients intake of picky eaters. Studies have shown that this 1 kilocal per meal oral nutritional supplement has high compliance and well tolerated, and there's no evidence of solid food placement, as well as it is effective in promoting weight gain in mild to moderate undernourished children. It is important for us to note the source of energy. Most of the energy from food comes from carbohydrate. Starches is one of them, sugars, as well as fibers. The main carbohydrate source in breast milk is lactose. It constitutes around 40% of energy. So it's important that whatever the ONS that we use, lactose is important. Lactose is the natural milk sugar present in milk, and it exhibits various benefits, which is prebiotic effect on gut microbiota. It enhances calcium absorption, as well as it is less sweet compared to sucrose. And early exposure to sweetened food like sucrose will lead to preference towards sweet food in later life. Excessive intake of sucrose is shown to be associated with dental caries, obesity, cardiovascular disease, and diabetes. And there is a possibility that it will cause hyperactivity as well as other behavioral problems in children. What about protein? It is very important for us to look into protein and children's growth. Protein intake and quality are important determinants of growth. Protein quality indexes include the amino acid profile, digestibility, presence of inhibiting or enhancing components in the food ingested. A surplus of protein in the diet may reduce appetite and is an ineffective and costly source of energy. High quality protein is defined as protein that supports maximal growth. And a high quality protein based on the protein digestibility corrected amino acid score of more than 70% to 80% should be aimed for. There are strong evidence that show that adding animal source foods to diet, 1/3 of protein intake, is more likely to meet the amino acid and other nutrients needs of recovering children. When we talk about amino acid, it has been shown that arginine is able to stimulate the acute release of growth hormone and has been proposed to play a role in linear growth. Its deficiency has been shown to suppress growth. Arginine stimulates collagen production for bone and cartilage, as well as the precursor for nitric oxide. And it's become very essential during stress states. Arginine also activates immune mediators. Other than that, arginine also play a role in giving a signal to the mTOR, which is the major regulator of growth for anabolism. What about fiber? It has been shown that the fiber intake in picky eaters is much lower compared to the non-picky eaters. And because of that, there is an increase in prevalence of having constipation. Having good fiber intake also improves the gut microbiota. Vitamin K, as we all know, is very important as one of the factors that is important in coagulation of blood. When we talk about vitamin K, it is important for us to understand that there are two different types, two different forms, which are vitamin K1 and vitamin K2. The table on the left shows you the sources of vitamin K1 and vitamin K2. For bone mineralization, vitamin K acts as a cofactor for activating osteocalcin associated with building calcium into the bone. Vitamin K status is associated with more pronounced increase in both bone mass in children. So in conclusion, picky eaters in Malaysia, from the study that we had, 13 of them had growth faltering and about 20% of them had short stature. When we look into growth faltering, it is significantly associated with parental concern about feeding, food refusal, as well as presence of at least one organic red flags. Early detection, which is regular measurement and growth monitoring, and looking at the A, B, C of the assessment is necessary, and please be watchful of the red flags. Authoritative parental behavior, as well as parenting styles, is vital for optimum growth. Appropriate nutrition and education is vital in supporting picky eaters. Thank you.
Thank you, Yazid, for sharing your approach in managing picky eaters as a clinician. For those of you, we are getting quite a number of questions now, and we'd like to have some more questions coming in. So those questions will be answered at the end of all of this, at the end of the session today. Right now, we're going to have some case studies. We have prepared a total of 3 cases today, where first we'll hear from Prof. Yazid, and then from 2 other case studies from Chris. And any questions that are related to the case studies will be addressed immediately after each case study. So let's keep those questions coming. So for the first case, let's hear from Prof. Yazid.
Let's go on to our clinical case. I would like to share with you a case that I've managed. This is about Adam, a 3-year-old toddler who was brought to my clinic by his parents with concerns that he is small size. He was born at term, weighing 3 kilograms, and his current weight is 13 kilograms and height 91 centimeter. He stays with his grandparents during the day because both parents are working. This is very important information. So how would you now assess Adam? What information do you need in order to advise and assure his parents regarding his growth? What are the things that we need to do here? Again, we look into the approach to picky eaters. We have to look into the history, the anthropometrics, as we talked about earlier, some physical examination, as well as systems review, looking at the organic red flags, as well as behavioral red flags, before we proceed further into looking at the biochemical markers. So in his situation here, the clinical complaint is that he is short compared to his peers. There is no known medical or surgical problems. Social history, he's living with his grandparents when the parents are at work. But most of the time when the parents came back home, he's very clingy and he wants all the attention from his parents. There's no other family members. He's the only child. And the dietary and feeding history tells us that there is no organic red flags or even the behavioral red flags apart from the parenting behavior, which is really very permissive. Most of the time, Adam is given the liberty to choose his food. And despite complaint by the grandparents that Adam is picky, the parents at this point in time still think that Adam is taking enough food that make sure that he has a proper growth. So why do we monitor his growth? This is important that we need to determine normality. And then we want to decide if he is in the optimal growth chart. So as for Adam, why do we need to monitor his growth? As the parents brought him and mentioned to you that he is small size, we need to determine whether this is a normality. We need to decide if he does have problem with his growth. We need to then reassure the anxious parents, as well as try to detect abnormal growth early in order to allow timely intervention. Let us look at Adam. He was born with birth weight of 3 kilograms, and at 3 years old, his weight is just above 15th percentile. What about his height? Unfortunately, his height is below the 15th percentile. So here I would like to introduce to you what does it mean by parental height. Does it matter when we talk about the height of a child? When we calculate for mid-parental height, we need to understand there is a difference between a boy and a girl. And how do you calculate that? Basically for boys, you have to add 13 centimeter to the mom plus the dad's height and then divide by 2. As for the girls, you have to minus 13 from the dad's height and divide by 2, whereby from there you have the mid-parental height target range, which is at MPH plus minus 10 centimeter. As for Adam, because of the father and the mother are tall at 178 centimeter and the mother 170 centimeter respectively, we note from here that the mid-parental height for Adam is actually between 50th to 75th percentile. As he is currently at below 15th percentile, that makes Adam very short compared to the mid-parental height. So is this an issue? Although we know that short stature is defined as anyone below the 3rd percentile, but as for Adam, due to the height of the parents, he is considered as short for the genetic potential. However, he does not cross down any 2 growth percentiles, but he does have some problem with his weight gain over the last 3 months. So it is important for us to evaluate his nutritional intake. We either can do the 24-hour diet recall or 3-day food diary. And in his situation, we did the 24-hour diet recall. We tried to determine his meal times, his food variety and quantity, as well as food textures. As during the day, he is mainly being with the grandparents. Most of the time in this situation, it is very difficult for us to get the history just from the parents alone. We need to bring in the grandmother to talk about the food variety and the food quantity that he takes every day. Then we assess the calorie intake. We need to determine whether he had sufficient calories that he consumed every day, looking into the 4 main food groups, the dairy, the cereals, the protein, as well as the fruit and vegetable. And if it is not sufficient, we definitely need to look into that in more detail. We also assess the food variety score, looking at the composite dish, day-to-day food intake, looking at the dietary diversity score, as well as the food variety score. We end up coming up with this sample of the diet and calorie intake for Adam. As you can see from here, it's very detailed. It involves all the food groups, and the diet plan involves all the different timing, the different meals. Yeah, basically from breakfast, lunch, dinner, as well as the snacks. If there is any opportunity that we need to use carbory or the MCT oil to improve the calorie intake for a patient, we then need to use all that. We also have to look into the parenting styles of these parents. As he is the only child, and as we know earlier that the parents are more of the permissive type, definitely there will be a lot of indulgence. We need to then really look and talk to the parents about trying to change their parenting styles toward a more authoritative type, a more responsive in terms of the feeding behavior. So at the end of the day, we need to decide whether Adam has growth issues or not. By looking at step 1 here, clearly we can see that Adam is short for the genetic potential, where his height is more than 1.5 standard deviation below the mid-parental height. But he did not have any of this problem of malnutrition, chronic inflammatory disorders, systemic chronic diseases, malformation or syndromes like Turner syndrome, or even the hypothyroidism. Because of there is no checkbox on the step 2, he should be referred to the appropriate specialist for diagnosis and treatment, as well as counseling. Basically, Adam needs to be referred to the pediatric endocrinologist. Thank you.
Thank you, Yazid. That was a very interesting case. So we'd like to hear the dietitian's perspective. So Chris, based on what Prof. Yazid has shared, is there anything that you'd like to add from your perspective as a dietitian? Over to you, Chris.
Well, thank you. That was a very clear, very nice presentation with a very important message. I would really just like to highlight 3 key points to extend on what you've already mentioned. The first, I think, was your key message about measuring mid-parentile centile. in children where there are concerns about their stature. And of course, this is really important. One of the clinical points that we should remember with this is the importance of us taking the measurements from the parents. It may just be a case of the UK or America, but generally we find in some of our research that the man overestimates his height when asked, and the women tend to get their height correct. So I think it's important when you're using mid-parentile centiles as a diagnostic tool that we actually take these measurements ourselves, and certainly that's what we try to do here. The second point I would make, I think you made it very clear that the importance of the dietary assessment to come from the main carer is really important. And in your case, you mentioned that the grandparents were the main carers during the day. So that information on how the child eats and what they eat should come really from them, so that it is reliable and that the diet information provided is good quality. And the last point was just, you showed very nicely a plan that would have been provided to that child. And the most important point here, which I'm very glad you discussed, was to give amounts of foods within those plans. Because what we commonly see is parents may lose perspective of what they believe is a normal amount of food for their child to be eating. So doing what you've done, which is to give portion sizes or weights of foods, is very, very useful at defining that for parents. And certainly online, there's some very good visual pictorial guides of average portion sizes for age. And again, these can be very useful in the children that we see to provide the parents with something to try to follow that will give them reassurance that their child is eating enough or that it's within normal ranges. That was a very lovely presentation. Thank you.
Thank you. Let's see what the audience, some questions from the audience. Have we got any questions? I think we have a few that's, okay, if both parents are short in stature, does it mean the child will grow up short? I think that's yours, is it?
Thank you, Dr. Zul. I think it is very important for us to also determine why the parents are short. I think it's important, as I showed you in the first case earlier, the need for us to measure, and Chris made it very clear just now, we need to measure themselves. I think when we measure the parents, when they come to our clinic, they feel important, yeah, rather than just asking them what's their height. We in Malaysia, unfortunately, are considered to be basically in our population, we are quite short compared to the Europeans and Americans. But we need to understand first whether that short stature that the parents has is just because of genetic, or is it also because that the parents themselves were having some nutrition issue when they were young, and because of that they did not have an optimum height. So a simple message is that short parents below the normal population height does not mean that the child should continue to be as what the parents are. I think it's very important for us to assess the whole picture.
Right. So nutrition can modify the final height.
Definitely, nutrition can define, and I think I've mentioned this many times. We just look at the Japanese and the Koreans. They were much shorter than us when they came to Malaysia in 1940. But as you see now, their average height, both the Japanese and Koreans are much taller than Malaysian. I think when you change your perspective in terms of the nutrition from the early age, especially the first 5 years of life, you can make a difference. I think that's very important.
Okay. Do you have any comments, Chris, or are you happy with it?
No, I mean, my only comment would just be sometimes it's important to reassure parents that the 50th centile is not necessarily a target of optimal growth. It's just representative of the average. So I think, yes, I would echo all the points, Professor Yusuf, you made as well.
Okay, so let's see if there are any other questions. Okay, how do you limit meal time to below 25 minutes? I think this is a question for Chris first.
Well, I think this is a very good question. And I think it's really a very important and practical piece of advice that we can give families who have children with difficulties with picky eating, because limiting the meal is something that will help meal times be more positive. Certainly using a visual clock for children can be very helpful. So actually having a clock with hands so the child can see how much time is left of the meal time can be very useful, rather than the parent just telling them. So I think that's important, to have a visual display of the time. And I think it's important for the parents also to remain strict about that meal timing as well. So actually being consistent with their approach to setting that 25 minutes and following it through, and that is an approach used by the entire family, whether it's the mother for the mealtime or the father or the grandparents. That consistency is really important too.
Okay, very great answer. We don't have much time for any more questions, so we'll move on to case study number 2. So Chris, over to you.
So now I wanted to share with you a case study. This was a 5-year-old girl who presented to us with concerns from the family surrounding her growth pattern. There were also concerns surrounding the variety of foods she ate. The family felt no more than around 10 foods. She had a reluctance of trying new foods. She was otherwise well, with no significant medical history to note, attending school and developing normally. Now, some of the things about this case study are very reassuring. We know that picky eating occurs commonly in this time frame, and generally we're reassured about growth. However, we owe every child that we see that presents with picky eating a thorough assessment. So this is what we did for this patient. Firstly, we began by looking at the anthropometric markers. If you look at the child's weight, you can see that there has been a fall off in their tracking of the previous centile. We can see when you look at the child's height trajectory that this has been sustained, and this is reassuring. However, when you look at the Z-score of this child, you can see it's approaching -2. So when we look at this child objectively from their growth pattern, we see their weight is out of proportion to their height. We see the history of growth was historically good, but there is an acute fall off. We looked at the mid-parentile centiles. These were appropriate, which were reassuring. But clearly, this growth pattern is a concern. Because of the concern around the growth pattern, this child went through a full biochemical workup, which included looking at some micronutrients. And you can see that her iron and zinc levels were both borderline low. Importantly, you see we also investigated her inflammatory response at the same time, that these were normal, which meant that we felt more confident about reassuring, interpreting these blood results. Clinically, the child was assessed. There were no signs of any organic concerning features. However, it was noted that she had growth failure, which is a red flag. We then undertook a detailed dietary assessment. Considering the amount of growth failure that we saw, we undertook a 4-day food diary for this child, which we then took the time to analyze given the clinical picture. And you can see the results presented here in bar chart form. And you see that her calorie intake is suboptimal, falling below the 100% target. And you can see other micronutrients such as iron and zinc and iodine are also falling below the recommendations. Looking at her macronutrients, her fiber intake was also low. Remembering it's not just what the child eats, it's how they eat. We undertook a questionnaire, and you can see the results of this here. And what was clear was that eating behaviors were very difficult at meal times, with meal times lasting a long time with a lot of distress. So what do we do with this type of child? Well, the first thing we do is to address the nutritional failure. And to do this, we used a 1 calorie per meal oral supplement. And the reason we did this was because we were then able to address the caloric deficiency, as well as the deficiencies that we identified both biochemically and with our dietary assessment of iron and zinc and other micronutrients. And you'll be aware of the supportive data in using oral supplements in mild to moderate picky eating children when they're given in combination with nutritional counselling. The other advantage to using the oral supplement in this case was it allowed the parents to feel reassured that the nutrition was better. And this allowed them to worry less about the nutrition, which allowed them to concentrate more on managing the difficult behaviours. So the difficult behaviours we had to address, and as I said, the key things that we noticed were the length of time the meal times were lasting, and the fact that meal times always ended in the child becoming distressed. So what we suggested to the parents was a time limit on the meals of around 20 minutes. And there is some good data to support this. Laurie Stark and colleagues from the States showed in a study filming meal times using a group of organic disease children, cystic fibrosis, and otherwise well children, and showed that the longer the meal time lasts, the more difficult the behaviours. So the second half of the meal time in this study often related to less bites being taken of the food, more refusal behaviours, and more non-compliant behaviours. And so this principle is fairly clear in picky eating children. The longer the mealtime lasts, the less likely it is to be nutritionally successful, and the less likely it is to be behavioural successfully. The other actions that we wanted to take were surrounding positive end of meal times and also positive phrasing. Specifically, what we wanted to do was ensure that the family used positive for positive phrasing. So rather than saying to the child, if you don't follow this or don't eat this meal, you can't play on the computer, they were using the phrasing, if you do eat this meal, then you can play on the computer or play a game. It's a subtle change, but can be very powerful in this age group of children. We then followed this child up around 6 months later, and what you see is an improvement in their growth trajectory. This then allowed us to wean away the oral supplement as it had completed its role, replenishing the nutritional inadequacy, and we're able to see some gentle improvements in the child's behaviour at meal times. And actually, we repeated the questionnaire, which was able to re-emphasise and illustrate to the parents that they had made some very positive steps forward from when they first began seeing us. Thank you.
Thank you, Chris. So one question to Prof. Yazid. What advice could we give to Malaysian parents? What would you say is a common struggle for Malaysian parents when it comes to the authoritarian style? Is it?
Yeah, I think we were brought up before by authoritarian parents.
Exactly.
I mean, as we become new parents, I think we should not be doing that. We should be changing that to more like the authoritative, but not too permissive and not ignorant. A lot of difficulty try to change that behavior, but I think as we grow older, as we move on, I think the new parents should try to change the way they actually manage their families to be more of the authoritative type. Bring in the child, like what Chris said just now, positive kind of parenting, positive paraphrasing. Those are very important rather than just telling the child, you must finish this, you have to finish that. It doesn't work very well now, not like during our time.
Right, okay. So I think we'll now open the questions to the audience. If there are any questions, okay. You mentioned authoritative parenting style is preferred. If the parents themselves are picky eaters, will it compound the issue? This is open to both of you. You want to start first?
Yeah, I think it's important that the parents themselves understand. I mean, I'm sure the parents who are picky eaters when they were young, now maybe some of them regret to be that picky because they probably are not having the optimum height or optimum growth. And I guess with the modern new information, a lot of knowledge that they can gather, they should not make, or they should not, bring up their kids to be also picky like them. I think that needs to be changed. Yeah.
Chris, you want to add from a Western perspective?
Yeah, I mean, this is a very good, very insightful question. It's an issue that we have. I think when you look at the data of how infants and how children learn about food and feeding, we're increasingly understanding the importance of modeling, the importance of children learning from what they see their parents do and what they see their parents eat. So if the parents are very picky eaters as adults, this will limit that environmental stimulus that the children get to learn and increase the variety of foods they have. So modeling is really very important. But if the parents are picky eating, then we have to look for other sources of modeling for that child. And this may be siblings, or it may come from friends at school, or it may come in terms of them inviting their own friends to come to eat with them at the meal times. I think it's very important that we provide those children with good modeling behaviors. I think as well, if the parents are very picky eaters, we look for alternatives as well. And there was a very nice review article in Appetite in 2017 that looked at all the experimental studies about children's learning and developing with food. And they identified, for example, gardening and cooking with the child as two key modeling interventions that could be used outside of the meal itself and outside the child actually eating. And both of those things showing very positive influence on helping the child develop with picky eating without actually the parents setting that example. It's a very good question.
Okay, let's see. Are there any other questions to come? Okay, what would be the examples of authoritative style? How to apply this in Malaysia, especially if both parents are working? Yeah, it's a Malaysian question, so
Okay.
it's all yours.
I mean, a lot of times we know when both parents are working, these kids are left to either the maid or even the grandparents. Yeah, and I think we need to understand that we need to inculcate even this type of authoritative parenting to those people who takes care of the children, to the grandparents as well as to the maid. I know that, as I mentioned earlier, when we were brought up, our parents are very authoritarian. We need to, like what Chris said just now, modeling, we have to let our parents, which basically the grandparents of the kids, to change the way they actually treat these children to be more of the authoritative type rather than just continue to follow what they actually did to us, the current parents. Yeah, I mean, to the maid, I think it's a bit difficult because a lot of time, these maids are basically less knowledgeable, but by being maid, they should follow what what we tell them to do. I think it's also important for us to teach them to make sure that the maid do not follow what the child wants. A lot of times when we see the maid will just follow what the child wants whenever it comes to the type of food that the child needs, and the maid will just follow in terms of the timing that is needed to complete the food. A lot of time our children takes more than 1 hour to complete rather than what Chris mentioned just now, just 20-25 minutes.
All right. I'm afraid we're short of time now, so we'll have to move on to the third case study, and is again yours, Chris, since you're the guest here.
So now I would like to share with you my third and final case study. So this case study surrounds a 3-year-old boy whose parents present to us due to lots of concern around the amount the child was eating. The family also reported that the child was not interested in meals and not interested in trying or even touching new foods. He was otherwise well, active, happy, and with no medical concerns and no use of medications. So in this case, just the same as all the others, we take us through a systematic assessment for this child. We began by looking at his anthropometric markers. We weighed and measured him and plotted him on the chart, so you can see that he was proportional on the lower centiles on the growth chart. However, he has been tracking this lower centile all of his life. And so this is reassuring that he is both in proportion and tracking a steady trend. Because he was on a lower centile and the family were concerned, we also undertook some additional anthropometric markers, particularly looking at head circumference and mid-arm circumference, and both of these within the same centile range as his weight and his height. We also looked at mid-parentile centile and found that his growth was what we would anticipate based on his genetics. So looking broadly at this child's anthropometric measurements, we saw this child had proportional growth, a steady history of growth pattern within his mid-parentile range with a good BMI-Z score and appropriate other anthropometric markers. We then undertook a biochemical assessment of this child to look at some aspects of his health, and we included some nutritional markers within these, and you can see these were all normal. Iron was borderline low, but not where we would address this, but his vitamin D was low. And certainly across Europe, we see this very commonly in this age group, and I understand from the data that this is also common in Southeast Asia too. In terms of a clinical assessment for him, the medical team assessed him but found no clear concerns of any organic underlying disease or any other conditions. When it came to the dietary assessment, of course, we began by looking at what he eats, and we used a 3-day food diary for him. And the reason we asked the family to record the food in this way, particularly so we could look at the quantity of the food he was eating, as this was the family's main concern. When we looked at the results of this, it was clear he had some low iron sources in his diet, and he didn't have a huge amount of vegetables or fruit in his diet. But his portion sizes were age appropriate. We undertook a behavior questionnaire looking at how he acted at mealtimes. One of the most interesting parts of this was the identification that he ate alone. He neither had brothers nor sisters, and he didn't eat at the same meal times as the rest of the family. When we looked at the parenting style for this child, it became very clear that the parents were offering him food whenever he wanted it, throughout the day. There was no structure to his meal times. And they would often prepare multiple food or meals for him in an effort to get him to eat something. So this very much fell in the indulgent parenting style that we know is not associated with poor growth. In fact, is more commonly associated with overweight status. So what did we do for this child? Well, firstly, we were able to reassure the family that his growth pattern was adequate and appropriate. We also were able to educate the families about the expected rate of weight gain in the coming 6 months, to provide them with some context which they would find reassuring. We also needed to educate the family on what was a normal amount for the child to eat. Now, to do this, we used pictures of average portion sizes for age. We don't have the copyrights to show you these, but you can look at the data and the publication associated that you see here. but using these visual representations was able to teach the family that actually what they were giving was a normal amount. And of course, from a nutritional point of view, we were able to treat his low vitamin D status. From a behavior point of view, the first and most important piece of advice we gave them was about modeling. Modeling, the child watching other members of family eating exactly the same foods, has long been recognized to have a very positive influence on picky eating behaviors. This child was not exposed to any modeling in his home environment. So we suggested to the families that at least one meal a day should be with a parent or a grandparent or a carer where he could watch and learn from them. The second key behavioral advice we gave was around the responsive feeding. When we looked at his parenting style, you remember it was very clear it was an indulgent parenting style. And this lacked the structure that would enable him to make improvements. So we taught them about responsive feeding, listening and responding to his cues, and setting structured meal times, which we knew would help in his behaviors. Following this child up 6 months later, you can see there is a continuation of his growth pattern, which is reassuring. We also recognized that the family had established at least one meal a day with another family member. This had begun to start to show improvements in his behaviors. And then we also repeated the questionnaire again for the family so that we could visually show them that the child had made improvements on his scores on the questionnaire, thus reassuring them that although progress was slow, he was indeed moving towards the right direction. Thank you.
Okay, thank you very much, Chris. So question for Prof. Yazid. Do you have any comments from your side?
Thank you, Dr. Zul. Thank you, Chris. That was very excellent cases, both case 2 and case 3. I think my comments for those 2 cases is actually for us in Malaysia, I think it's very, very important. As you can see from Chris, 2 cases, the importance of having a serial measurement. With the first case itself tells you already, if you don't have a serial measurement, you may not be doing much to the second case because the weight and the height is still above the 3rd percentile. But if you have a serial measurement, you then know that the child is just plateauing in terms of weight, and you will do more than just watching the child. And when the weight is plateaued like that, it's very important for us to move forward rather than just look at the A, by going forward to look at the B and the C, and then manage the child properly. As for the case 3, when we look at the serial growth measurement, both weight and height are tracking at the same centile. And because of that, BMI is good. So you want to look further into the parents, as we talked about initially in the first case. If the parents are also tracking at the same percentile height, that most likely the child do not have any issues. So you need to look further into the dietary behavior, the expectation of the parents. And clearly from what Chris had mentioned just now, there's a lot of expectation from these parents. But when we look further into the whole problem, the parents themselves have some issues. And correctly, when you start talking to the parents and put everything together, you manage to make sure that the child continues to grow normally. I think that's very important 2 cases. And that's the same thing that we see in Malaysia as well. And the last thing that I need to mention is that, as I showed you earlier in the first case that I presented, we only have 1 number. So when you have 1 number, it's very important for you to track them and get a serial growth of these children before you even say, thank you, bye-bye, you don't have to come to my clinic anymore, even though they are growing above the 3rd percentile.
Right. So it should be a practice for us to take the weight and height at every visit, right?
Exactly.
Yeah. Okay. That's the take-home message. All right. Let's see what questions we have. I think we have 1 question. All right. What are the key signs of picky eating? What are some of the standard questions to ask? which tool would you recommend to use in clinical setting? Either of you.
Yeah, I think Chris had that showed just now.
Yeah.
Chris, over to you.
Okay, thank you. So I think the signs of picky eating, there are lots of signs, as we mentioned. The characteristics that are most common would be an unwillingness to try new foods, so a reluctance to try new foods. And also we sometimes see that the child becoming less keen to eat foods that they historically have eaten. So foods that were part of their diet that they decide they no longer want to have. I think some of the key questions to ask are actually around what the child eats, paying particular attention to the key nutrients, such as iron sources, zinc sources, and protein sources. And in terms of behavioral, I believe one of the most important things to ask is to get the families to describe to you what happens at the mealtime. Specifically, what happens at the beginning, what happens during the meal, and what happens at the end. Because these can really help to pick out the best management approach. If the child is at the beginning of a meal very reluctant to come to the table, if the child gets upset before they've even sat down and seen the meal, then that's very much suggestive of the child having issues with the environment surrounding meal times. If the child during the meal begins happy but then deteriorates in their behavior or their attitudes during the meal, this may be more representative of the types of foods that are being offered rather than the environment itself. And looking at what happens at the end of the meal is very key, because if the meal times end with the child always becoming upset, then this very much guides us to around the parenting style, perhaps being that aggressive, punishing, or threatening style that is not going to help us make progress with picky eating children. So I think the standard things to ask are nutritionally about the key nutrients and behaviorally about what happens before, during, and at the end of the meal. And the tools that we would recommend in the clinical setting, probably the one I mentioned in the lecture earlier, the behavioral feeding questionnaire, the first one on that slide, is probably the most validated tool that we have. It's the one that's being used most widely and has probably the most application in picky eating. Thank you.
All right. Anything to add?
I think what Chris had mentioned is very important. I mean, there are some tools that we can use. Just questionnaire, you can actually give it to parents before the start of the clinic, or even when you need more information, then you can do the questionnaire, I mean, together with the parents, and then understand what are the issues that comes with it. I think what we have under our Malaysian Pediatric Association, we do have some questionnaires that we put up and try to make it very easy for us to use. Those of you can just go to the Malaysian Pediatric Association website, and you'll be able to get some of those questions. Yeah.
Okay, good. All right, so I'd like to now open to questions that are either related to the case study or any other questions that you have regarding this. So let's see what the questions are. Oh, we've got quite a number of questions. So this is an open session, so you can ask all you like. Let's see what's the first question. Okay, there it is. We know that catch-up growth too fast or slow is not ideal. How should catch-up growth be, and what's the ideal rate? Is it you want to take care of it?
Thank you very much for the question. I think this is excellent because we do not want to overdo and we do not want to underdo. Yeah, I think there are some data coming up to show that you need to do it usually in the span of about 6 months, but not too long before you see the improvement. Yeah, and I think what Chris has mentioned in terms of the 2 cases itself. I mean the follow-up after 6 months, you see the improvement. So that amount of time is needed. And to how far do you want to bring them? So there are some data to show that if you're going to bring them up, I mean, in terms of the weight gain, in terms of the height gain, usually you will try to bring them up into that between the 25th to the 75th percentile. You do not want to overdo or underdo in terms of their improvement in terms of the weight and the height. Chris, you have anything else to add?
Anything to add, Chris?
I think that's an excellent answer. I would just echo what you're saying. I think you're right. We have to find this balance between providing sufficient nutrition to support optimal growth, but avoiding providing excess where we may cause long-term negative health aspects in that child. I think it's a lot more defined in infancy. The WHO give us very nice guidelines from 2007, suggesting 10 to 20 grams per kilogram per day you might expect in an infant who you're trying to promote catch-up growth for, depending on the calories or the protein energy ratio. But in the older children that we're talking about today, I think absolutely, as you've said, it should be looking at a time frame of certainly months, definitely not days. And it's much more likely that rapid increases in weight over several days will be much more reflective of fluid status and less reflective of good quality balance of muscle and fat mass for the child. So absolutely echoing your point that following these children up is absolutely key, not allowing them either to not catch up, but also preventing them from overshooting and stimulating too fast a weight gain that may also cause problems.
Right. We've got a lot of questions now. Let's see what the next question is. Okay, how long should a child be on ONS? And when to wean off, and what would be a good alternative to high-calorie ONS? You want to start with that, Chris?
Yeah, thank you. It's a very good question. So how long should the child should be on the oral supplements for the time it takes for them to begin to show catch-up growth towards your proportional centile target? I think once you're seeing that improved weight velocity, when you're seeing the child cross centiles back up, at that point there may be a time to consider weaning down the oral supplement. Again, we want to find a balance in practice of getting the additional calories in to support that growth, but not allowing the oral supplement to displace the calories that would otherwise come from food. So normally once we're seeing the child approaching their proportional centile would be the time that I would begin to wean down the supplement use. And an alternative would certainly be something such as a milk-based drink, because when you look at oral supplements, they represent a balanced source of carbohydrates, proteins, and fats. And dairy products or plant milks provide that balance of those macronutrients too. So they can be an effective strategy as we wean down from oral supplements to promote those to replace them.
All right, let's next question. If a child has ASD, how to manage picky eating in this case? This is a question for Yazid.
I think both of us can join in there. I think, disorder, right? Yes, I mean, autism spectrum disorder children, as we know, they are difficult, they are picky, they may have some other issues on top of that. I mean, I've seen children with autism who come to me with severe vitamin D deficiency because of refusal to take all the dairy food and all that. And on top of that, the parents think that the child has eczema, and then because of that, avoiding all that problem. So I think in that kind of situation with ASD, there's a lot of work that needs to be put in, repetitive introduction of that kind of food. And we know for ASD, they are very picky, they are very choosy, very minimal number of food per day that is they are exposed to. And I think it's important that the parents, again, as what Chris liked to mention just now, the modeling, on top of the modeling is the repetitive introduction. I think those are the main things that we need to look at. I'm not sure whether Chris has other things that you want to add on.
Yeah, this is a
Yeah.
issue.
Yeah,
I'm sure you've handled cases of autism spectrum disorder, and how do you handle it?
Yeah, and it's a very good question. I think the most important lesson I've learned regarding managing this group of patients, particularly we do lots of our management with the psychology team, is the number one thing is being realistic with the parents that the children with ASD do take longer, as you've mentioned, to recover from picky eating behaviors, and their behaviors maybe, you know, represent the most difficult. So I think it's very important that we're realistic with our parents, that we tell them progress will be slow. You know, we're there to support them during that, but they have to understand that. Likewise, in ASD children, because progress may be slow, it may also be very subtle. And that's where using the questionnaires that you have developed and that we see available from other groups can be very, very useful at picking up those subtle improvements that may be missed by the parents, who may feel their child is making no progress. And you may feel the child is making no progress, but using those assessment tools can very nicely sometimes pick up those small, positive gold nuggets of improvement that provide reassurance to the parents that we are making progress, it's just slow. So they do represent a very difficult group of patients, but the same principles apply of modeling, responsive parenting, and timeframes. But again, looking more at the longer term picture for them recovering out of that and making progress. Very good question.
Yeah, so it involves a multidisciplinary kind of approach, right? And yeah. Okay, can we have the next question, please? We're getting quite a lot now. Is there any suggested supplement that can be given to increase the child's appetite? Multivitamins?
Chris, you want to take that up?
I
think this
I'll
is
try.
very common. Yeah, they will ask lots of all these questions, the parents. Yeah.
I mean, I think personally, you know, if the child has, of course, an iron deficiency anemia, that may well be playing a role in their appetite. So identifying if there's a micronutrient deficiency that may be coexisting and exacerbating the low appetite is helpful. In terms of an actual supplement that would help in the broader sense, I don't believe that any of the systematic reviews or Cochrane reviews have identified anything significant. I think personally, the advice I give parents are activity, fresh air, and regularity to meals are the best supplements to dietary intake to promote appetite. Increasingly, certainly in the UK and across the US, activity levels in children of picky eating behaviors are very poor because they spend more time on screens and less time being active and playing. So certainly reinforcing the message of activity, walking, being outside, playing with their friends is a natural appetite stimulant for us as a species, as is fresh air, and structured meal times play into the behavior to promote good appetite and regularity. Anything you would else like to add?
I think one of the things from Malaysian parents, a lot of Malaysian parents do not have structured meal times. Yeah, the breakfast, lunch, and dinner can be at any time. So that is also another problem when you are taking care of small children. Yeah, if you were to just eat at any time, there is no role model in that, and a lot of us do not sit at the table when we eat. We're everywhere. That is the Malaysian culture. Most of us are eating outside, and when you go out, you can see them take lunch at 3 p.m. or 4 p.m. and dinner probably at 9 or 10 p.m. So that kind of structured meal time that needs to be changed. I think in Malaysia, that problem of no structured meal time is there. It's really rampant.
Yeah, can I just ask an additional question? Is there a role for empirical sort of treatment or empirical supplements? Because if you know that the incidence of iron deficiency is that high, you know, is there a role for empirical treatment in resource depleted areas of the country?
I think that's a very nice question. I think that idea about supplementing based on the presentation of the child is obviously an option. And certainly in certain groups of our patients, for example, those born very prematurely, prophylactic supplementation of iron is something that we commonly do. I think the worry, certainly from an iron point of view, is about the impact on as a gastric irritant that we commonly see in children. So we don't personally prophylactically treat with iron unless we see that there's a deficiency either in the diet when it's assessed or an identification of a biochemical marker that would support it.
Just to add on to Dato' Zo's question just now, for the underprivileged group, I think as I put in my lecture just now, Malaysia is also one of the countries that has this triple burden, which is including anemia. And we do see some of our kids do have some issues with iron deficiency. And I think the use of this micronutrient powder would be a good way to help to improve in terms of their iron level. And probably at the same, and when you improve the iron deficiency, that may also improve the appetite of these children.
Yeah. And vitamin D as well. Okay, let's see what's the next question. This is specifically to Chris. Usually what you would advise to do if the child just keep the food in the mouth for a long time and do not want to swallow? This is I've seen patients like this.
Okay, so another good question. I mean, I think the most important thing is to identify whether there is a clinical reason that the child is pouching food or whether it is a behavioral reason. Certainly, we do see pouching or holding food in mouth as a time delaying tactic in picky eating children, but we also see it in children who may have issues with swallowing. So the first thing we would do would be to try to identify whether or not there's an organic reason, and this may come from an assessment by a speech therapist or an assessment by a specialist who can review the swallow mechanism. A crude way of identifying this in practice is to check whether the child does this practice with foods that they like as well as foods they don't like. And that will normally help to tease out if the child does it with every food, it would be more suggestive there may be something functional. If they just do it with foods they have a less preference for, it may be more behavioral. If it is behavioral, the priority is to try to build the child's confidence with swallowing the food. And this can be done either through the use of an agreed number of swallows, agreed number of chews before swallow, say 5 or 6, that the parents model, and also the use of chaining certain foods that are very similar. So if a child has problems with, for example, a certain type of meat, then we would try to chain other forms of meat that maybe wouldn't result in the child pouching to try to build their confidence and build their skills. But I think the most important point is to clearly identify whether there is a functional reason related to an issue with swallowing or whether it is behavioral and the reason why they're doing this.
Right, let's have the next question. Baby-led weaning has been gaining popularity instead of the conventional spoon feeding. So does baby-led weaning truly reduce the incidence of picky eaters? Chris?
Very nice question. So there is some data to support that this method of introducing foods into the child's diet may have some positive influence, particularly surrounding the neophobic response, so the fear of new foods around the ages of 18 months. So I think there are some very important positive benefits of baby-led weaning in the terms of the children learning about the textures of foods and about the skills related to self-feeding. But there are also risks of baby-led weaning in terms of the children not necessarily being able to achieve adequate, for example, iron intake because of their inability to chew meat that's not been processed down. So I think what we try certainly to recommend to our families is to use elements of baby-led weaning during the weaning process, allowing the child to get messy, allowing the child to get food on their face, allowing the child to self-feed, but also maintaining some levels of conventional weaning to allow for adequate nutrition. So it's really finding the balance between the benefits on behavioral development of baby-led weaning and adequate nutrition coming from conventional feeding.
Okay, I think we've run out of time, so there are a few more questions that we have managed to answer, but hopefully we can answer them at some time or email them. Thank you all for your questions, and I think we're going to have, before I close this session, we're going to have a last round of polling questions. And the first question is, the lectures has given some inspiration to make adjustment to my day-to-day practice. So do you agree with that, or you not agree with that, or it hasn't changed my practice at all? We have about 15 seconds to answer so that we know whether this has been of benefit to you. Okay, so we've got, we have the answers. Do we have the answers? Yeah, okay, right, wow, okay, 98% said that it has made an impact. All right, do we have a second question? Okay, what would you do differently to manage picky eaters now? The answer 1, plot the growth chart of my patients more often, encourage diet recall and understand family history of suspected picky eaters, use the ABC to assess growth of picky eaters, use of oral nutritional supplement to improve nutritional status of picky eaters as required, educate the parents on parenting style, and all of the above. This should be very easy to answer. Okay, now we're getting some answers. Right, let's see what the answers are like. Well, okay, or 91% answered all of them. All right, fine, that's good. So there is some take-home messages that you've taken from this. Thank you very much for attending. And as we have a few more minutes, we'd like to hear from you what other topics that you'd like to hear in the future. And I think you can include that in and tell us what you want from us for the future in discussions. And with that, I will pass back to the MC, Alvin, for his final rounds of announcement.
Thank you once again so much, Dr. Zul, Prof Yazid, along with Chris. Thank you for sharing your expert thoughts and opinions with us. And to everyone, we trust that you found our symposium today to be very fruitful and productive. Again, just echoing Dr. Zul, please feel free to let us know via the chat icon below your screens. Again, if there's any specific topic or topics that you'd like to see more of in our future symposiums to come. All right. Next up, folks, we will be sharing with you in a very short while the QR code for you to scan and claim your CPD points for today's symposium. But before we go into that, just a very quick final set of evaluation questions that we'd like to ask of you. And this is, of course, to provide feedback to the organizers and also for you to claim your certificate of attendance. So again, you know the drill, hands on the mouse right there or hands on your screen. Let's go through the questions very quickly. First and foremost, how would you rate the length of today's symposium? How would you rate the length of today's symposium? go ahead, just click your answer in. We won't be sharing the results for this one. Again, this is just to gather your feedback as we move on to the next question. How relevant is the symposium information to your daily practice? All right, again, how relevant is the symposium information to your daily practice? Feel free to let us know. Third one, do you feel that the symposium today has helped you gain new knowledge? Okay, that's the third one. Let's move on to the fourth one. Would you share your learning, the recordings of the symposium, to your colleague? Next one, how easy was it to navigate this event? And of course, the next one, very exciting indeed. How interested would you be to join a similar event in the future? It is in the pipeline. We are planning for a lot more future symposiums to come your way. So again, please feel free to share with us all other topics that you would love to be talking about and hearing from us about. And last but not least, final question, overall, how would you rate this first ever 100% virtual conference symposium? So share your thoughts with us. And once again, folks, today we've really had a lot of questions coming in from you folks. We've had a lot of engagement with you. A lot of you have given us your answers and all of that. And we just want to say a big thank you to all of you for joining us and, just having this conversation with us. We really appreciate that. Well, with that, folks, please go to your MMA scanner app. Again, this is the time that we're going to be sharing with you. There you go, the QR code there. You've got to scan the QR code by going to your MMA scanner app. Okay, all of you should have it by now. Just go ahead and scan it. And then this will enable you to lock in your 2 CPD points for today's symposium. All right, for those who are unable to scan it right now, don't worry, we'll manually get it across to you. Now, with that, folks, once again, on behalf of the Malaysian Pediatric Association, along with the Malaysian Medical Association, in partnership, of course, with the Non-Nutrition Research, we want to say a big thank you to all of you for taking the time to be with us in today's symposium. And we'll definitely be looking forward to seeing you folks the next time around. Until then, my name is Melvin Area. On behalf of all our speakers, we say thank you for joining us. Stay safe, stay healthy, and we look forward to seeing you again the next time around. Have a good evening.
Good evening. Thank you for having me here to share with you on the iron deficiency anemia. I believe that this is a growing public health emergency, and I think we as the healthcare providers and those involved with health in children would like to know a little bit on iron deficiency anemia and what we can do to help prevent this from continue to rise in terms of the prevalence in Malaysia. Good evening. Thank you for having me here to share with you on the iron deficiency anemia. I believe that this is a growing public health emergency, and I think we as the healthcare providers and those involved with health in children would like to know a little bit on iron deficiency anemia and what we can do to help prevent this from continue to rise in terms of the prevalence in Malaysia. Good evening. Thank you for having me here to share with you on the iron deficiency anemia. I believe that this is a growing public health emergency, and I think we as the healthcare providers and those involved with health in children would like to know a little bit on iron deficiency anemia and what we can do to help prevent this from continue to rise in terms of the prevalence in Malaysia.